Welcome to Endometriosis Voices, listening to lived experiences, learning from science. I am Isaac Chebafo, and the topic for today's episode is endometriosis and dismissive doctors, how to ask for help and referral. If you are living with endometriosis or waiting for a diagnosis, you already know that pain is not just a symptom. It can shape your work, your personality, your relationships, and your plans. You may also be aware that it takes anywhere from 7 to 10 years from the first symptoms to receive an endometriosis diagnosis. Independent studies have tried to understand why it takes such a long time for endometriosis to be diagnosed, and a number of factors have been adduced to explain this. Common among them is that most endometriosis patients feel unheard or dismissed in early consultations. Today is not about blaming individual GPs. It's about handing you practical tools so that when you do see a GP who seems to minimize your symptoms, you have ways to describe your pain in clear and convincing language, stay calm and confident, and ask for a referral to an endometriosis specialist in a way that is firm but respectful. As we walk through this episode, this is what I want you to have at the back of your mind. If you have severe period pain or any of the endometriosis-like symptoms, for which reason you've booked an appointment, the outcome you are looking for is to be able to see an endometriosis expert clinician to be able to rule it out or diagnose it if it exists. Therefore, as you walk to the consultation room, endeavor to make it a goal that anything that you are going to do is going to give you the outcome that you are looking for. Otherwise, just don't do it. In spite of the need to have this thought before your appointment, you know your body far better than anyone else ever would. So, you don't have to accept nothing is wrong when you know deep down that something is not right, regardless of who that information is coming from. You don't have to yell or fight to be taken seriously. There is always a middle ground. Before we consider the specifics, there is a need to establish the context under which dismissal happens. Research with GPs and patients have identified a number of layers that leads to delays in endometriosis diagnosis. One of them is that endometriosis itself is a very complex disease. Symptoms can include pain, bowel issues, bladder symptoms, fatigue, infertility, among several other clinical manifestations. And these symptoms are common to other diseases that are well known by the clinicians. Second, appointment times are very short. For a complex disease like endometriosis, where symptoms can differ from person to person, a 10 to 15 minutes time is not enough to cover many of the layers to be able to unravel or come out about a suspicion of endometriosis and recommend an appropriate referral. Third, endometriosis-specific training in medical school is very new. Remember, not all GPs have had an in-depth education on endometriosis, especially the older generations. And then finally, cultural beliefs. Menstruation and pain is still often seen as something that should be tolerated rather than investigate. I am not in any way indicating that any of the factors that I listed above makes it okay for your pain to be brushed aside. My conviction is that knowing the context makes it possible to approach the consultation as two people working in a pressured system rather than as enemies. I am also not here to tone police you or teach you how to communicate your symptoms. We can sit here all day and talk about how doctors don't listen, And the doctors can also come out and say, we don't understand what you are saying. The question is, does it give us the outcome that we want? If it doesn't, then there's no point wasting resources on that argument. Each one of you bring a wealth of resources to the consultation room. You, as the endometriosis sufferer, brings detailed knowledge of your body and your life experiences. The GP brings medical training and access to tests and the referral system. Good care can always happen when these two kinds of expertise meet and work together. Review of diagnosis delays show that vague descriptions like "I have bad periods" makes it harder for clinicians to spot endometriosis early. For at least 2 to 3 cycles before your appointment, document in details where the pain is. Is it in the pelvis? Is it at the lower back? Is it at the rectum? Is it in the bladder? Is it in the thighs? Be specific about where the pain is. And when it occurs, is it before period, during period, mid-cycle, during sex, with bowel or bladder movement? Document pain intensity on a scale. For instance, you can use the 0 to 10 scale, where 0 is nothing or no pain at all, and then 10 is the most excruciating pain you've ever felt. Many people are familiar with this kind of scale and will be able to appreciate it better when you use that scale to describe the intensity of your pain. Then you should also add in clear details how this pain interferes with your schedule and personal life. Does it affect your work? Does it prevent you from going to school? Does it have any effect on how much or how long you can exercise? Does it have any plans on where you participate in social activities? Does it affect your sleep cycle and intimacy? So, for instance, instead of saying, "My period hurt," you might want to say, "For the last 6 months, on the last 3 days of every cycle, my pelvic pain is 8 out of 10. I vomit, I can't stand upright, and often miss work." Global Endometriosis Management Guidelines has organized these kind of impact as significant red flags that should prompt further assessment or a referral. What this documentation will help you to determine as an endometriosis sufferer is the consistency of your symptoms, whether they are the same each time they occur or they differ, and the intensity and the extent to which it interferes in your daily life. Once you've had that documented, then you need to be able to write down at least 2 or 3 outcomes you are looking for in the appointment. And these are going to follow right after you've communicated these symptoms that you've documented. So for instance, if you are just interested to know whether all these symptoms that you are experiencing is an indication or could mean that endometriosis is suspected, you need to write it down and be able to communicate it immediately after you've finished communicating your symptoms. Or if you are interested in developing a plan for just managing the pain and the symptoms, you need to write it down. If the outcome of the appointment is a referral to see a gynecologist or an endometriosis expert clinician, you need to also write that one down. It can be very frustrating to remember the last person you spoke on the phone with the last 2 weeks. Endometriosis symptoms can be very chaotic and can differ from cycle to cycle or month to month. So, having a document like that enables you to stay on track during the consultation. Now you have the symptoms for a few cycles documented. You have the outcome that you are looking for also documented, and you have finally entered into the consultation room for your appointment. It is one thing writing them and another thing communicating them. So this is a suggestion of how you could communicate everything that you've documented during the consultation. Research on chronic pain communication shows that visits go better when both sides feel heard and involved in decision making. A few tools can help make a big difference during the consultation. A clear opening is very important. Use I statements like I feel like, I have been experiencing, and then name endometriosis. Naming the disease doesn't harm. It is the disease itself that harms. As much as possible, be collaborative. One important feature of collaboration is an appreciation of effort. And so, for instance, you could start your conversation by appreciating them for seeing you despite the busy schedules that they have. Also acknowledge that you're very much aware that appointment times are very short, and then you can begin to go ahead and tell them what you want to focus on today. And so, for instance, you could say, "Thank you for seeing me today. I know appointments are short. I really appreciate your time. I have been going through pelvic pain that is affecting my daily life, and I would like to focus on that if we can for today's appointment." Then you can bring out your notes. "I've been tracking my symptoms for the past few months. Would you be willing to look at this summary with me?" So by presenting it this way, you are inviting for collaboration instead of an information overload. This also sets the scene to indicate that you are able and willing to play a significant role in the appointment schedule. After you've gone through the symptoms with the GP, there could be one of two outcomes. One is when you are fortunate enough that the GP is endometriosis aware and familiar with endometriosis management guidelines, and say that these symptoms that you've mentioned are indicated red flags in endometriosis guidelines that requires a referral and extra attention, and then gives you a referral. Or two, where the GP you've seen is not endometriosis aware, and for that matter just says it is part of period or just recommend pain medication. If this is the outcome, you may be tempted to use phrases like, "I feel like you are not taking me seriously." As much as possible, resist and refrain from such statement that is likely to invite defense rather than collaboration. So you could rather follow it with something like, "I'm feeling quite worried because the pain is getting worse. I'm scared we might be missing something important." Don't say the GP might be missing something important. If you happen to be sitting in an egomaniac GP's office who thinks their years in medical school makes them know more or far better than you and your body, you probably would not have a good outcome. But if you say "we," you are still inviting collaboration and saying that whatever is being missed, you are playing a role in it. Remember, we have an outcome that we are looking for from this appointment, and that is what we want to get. The other part of it is that the I statement shares your experience without blaming the GP's intention. So when you say, "I'm feeling quite worried," you are talking about what you feel without necessarily dismissing what that GP had initially suggested, whether it's being pain medication or just go and take a rest because you are stressed. Secondly, it is okay to mention the word endometriosis at this point. So you might want to also say something like, "I've learned a bit about endometriosis from trusted health websites and patient organizations. My symptoms," then you follow it with the list of symptoms that you have discussed prior: severe period pain, pain during intercourse, pain during bowel changes, seems similar. I would rather value your thoughts on whether endometriosis could be part of what is going on. Again, you've given them a wealth of information. You are inviting collaboration, and it is almost unlikely for such a statement to query a response. rather than the collaboration it is seeking to incite. And then you might follow it. If there are any other steps you might want us to consider, again, want us to consider. You are not putting the entire authority into their hands, and you are not trying to take away their expertise as a clinician and the access to test and the referral system. Secondly, in that statement, you didn't just point it out that you have endometriosis. You are saying you are having some symptoms that you think are similar to what endometriosis symptoms as illustrated in international guidelines and or trusted healthcare sources are. And so you think it is something that you want to look into. Based on what I have shared, what conditions are you thinking about? This is an invitation to collaborate in the discussion based on the extra layer of information that you've now added to the discussion that you've already had. And you can come out with a number of conditions. Endometriosis could come in as one of the options of the conditions they are thinking about, or it could not even come in at all. If it comes in the options, great. If it doesn't come in, we are going to introduce endometriosis into it, because in our previous discussion, we had already mentioned that we think or we suspect that it may be endometriosis because the symptoms look like what the endometriosis management guidelines have listed as what eventually leads to endometriosis diagnosis. And so you could go like, if this turns out to be endometriosis, what would be the usual process from here? Now, if endometriosis was mentioned, it falls into place. If endometriosis was not mentioned, it still falls into place that, okay, you've heard all the other options, but you didn't hear about endometriosis. So if it is endometriosis that is suspected, what are we going to do from here? Never at any point indicate like you know better than the clinician, but never at any point also indicate that you've taken yourself away from the decision-making process. If your clinician comes back with a number of plans that could be considered if endometriosis is suspected, one of them would include pain medication, which usually is the first line of treatment or management prior to waiting for the endometriosis diagnosis itself. It is fine. You might want to follow it like, if we try this first plan, which is likely going to be either pain medication or any other medication that they are going to offer for the pain itself and not the underlying cause. So if we try this plan and it doesn't help, when do you think would be appropriate or a reasonable time to review and think about referral? What this kind of question will query is that, one, you respect their expertise, which is what every GP would expect you to do, because if you didn't, then there was no point coming to their office in the first place. But also, you signal that you are able to advocate for yourself and be part of the decision-making process, and not just a passive recipient of information during the appointment. So the line that we have told is when the clinician is trying to reason with you in spite of their dismissive behavior. But then what if the clinician continuously maintains their stance to dismiss and brush off your pain? How do you approach it? And so for instance, if after saying that you've read from reputable health sources and endometriosis management guidelines, and the pain that you are having and symptoms you are having is similar to what has been listed to raise suspicion for endometriosis, and then they hit you back with something like, lots of women have bad period, it's normal, then what should you do? You could reply with something like, I understand that period pain can be common. At the same time, my pain is so strong that I miss work and sometimes I can't even stand up, which is something you've documented and probably have gone through again. Reiterate it. There's absolutely nothing wrong with it. Look, see, from what I have read, when pain is intense and it is this frequent, it can be a sign of a condition like endometriosis. and guidelines suggest looking into it more. Could we talk about the next steps for investigating this? So what this does is that you are acknowledging their point. You are not also completely dismissing the fact that they have had a lot of women probably come to their office over the years complaining about pelvic pain or period pain. Indeed, a lot of women may have passed through their office complaining about period pain. So that is a fact. It is common. But the part where they got it wrong is saying it is normal. It is not normal. So you don't dismiss that outright. You are acknowledging that indeed period pain is something that is common. They probably see tens to hundreds of women complaining about period pain. You acknowledge that. Your case is different, and that is why you think it requires further investigation. So that clinician who is dismissing your pain does not feel being dismissed, which can raise some egos and defensive moods that we are not interested in seeing. Remember, the aims for which this appointment were attended did not include infuriating the GP who is supposed to give us the referral or a good management plan that we want. A second example could be one who had already requested that, okay, let's go and do some imaging. And then the imaging report may have come back and you are going for a follow-up to discuss what the outcome of the imaging is. And so in this case, that GP might have worked with you and referred you for some imaging to be able to look at the next steps. The imaging came and then everything looks okay on the scan. So it could be like, yeah, so I took all the symptoms and the information that we discussed in our previous appointment into advisement and requested for some imaging. Now your scans have come and they look normal, so there's nothing to worry about. In this case, this is where what I said about you knowing your body far better than anyone else ever would, and for that matter, you shouldn't take nothing is wrong for an answer when you know something is not right, comes in. But you are not going to say it like that. So you, one, acknowledge that the scans are clean, because indeed the scans are clean. But that does not mean that you don't feel pelvic pain. So you could go like, I'm relieved that the scans are normal and don't show that anything dangerous is happening. However, I have also read that superficial endometriosis hardly gets recognized in standard imaging. And considering that my pain is so excruciating and affects my day-to-day life and work, I am still worried that something important is happening that the imaging couldn't pick up. So what would you recommend when scans are normal but the symptoms are this severe? So now, you've brought in another layer of information. Remember, when the scans are recommended, it's a step up from the initial appointment. So you need to go along with it. Now the imaging results are in, it's showing nothing. What other information could be added on to prompt further investigation? That is what you've given. If you have a GP that is, again, endometriosis aware, they really know this and understand that further investigation needs to happen. But if you have a GP who is not endometriosis aware or just want to be dismissive, they might just hit you back. It might just be stress and maybe you need to just have some rest. Anytime the GP tells you something, you shouldn't dismiss it outright, just as you are not happy when your submissions are dismissed. We are going to make sure we are collaborating, like each of us have a wealth of information that we are bringing together to get the outcome that we want. And so you could respond to that with the acknowledgement that you are aware that stress can make a lot of things harder, but then indicate that these pain and symptoms that you are feeling appears to sync with your menstrual cycle. Remember, we had documentation for 2-3 cycles before the earlier appointment, and then probably have gone for the imaging and gone for 1 or 2 other cycles through which you are still documenting the symptoms and have added another wealth of information to it. And now you can certainly see that this pain happens at specific days during the cycle, and so it is completely tied to your menstrual cycle rather than stress. If it is completely tied to your cycle, then you refer back to the sources that you read that says that the symptoms that you mentioned are usually tied to the menstrual cycle. And then after that, invite for collaboration again. Will you be able to help look at that possibility more closely? That one, the imaging is right, there's nothing wrong, but it could have missed it because it is superficial lesion. And you understand that stress could cause a lot of things, including all those pain and fatigue and all that. But in your case, it is different because it is tied closely to your menstrual cycle, and that is a red flag in endometriosis guidelines that demands or warrants further or critical investigation. But then you are not telling them that is what it is. You are inviting them to contribute to a possibility of having a closer look at your condition because of these other dynamics that you've already introduced. In your conversation, anytime the GP says something and there's an element of truth, acknowledge the part that is true and then add the wealth of knowledge and information that you have. That indicates that your case is different and might not necessarily be what the GP had said. If at this point the clinician is still refusing to request or give you a referral, then request for it yourself. Bring it into the discussion. Because the point is that the endometriosis management guidelines clearly states that referral to a gynecologist or endometriosis services often recommended when pain is severe and or persistent. So it could be severe and not persistent, but it could also be severe and persistent, either of the two. When the first line treatment does not work or is not giving the maximum outcome. So when you are giving pain medication or hormonal treatment options and they don't work, then an extra or critical examination is supposed to be given to that individual. And also when there are worrying findings on the examination or the scan, which could have been the case or could have not been the case, but still does not rule out a possibility that endometriosis may exist. Finally, but important, is if there are fertility concerns. And so here is how you inject the referral request into the conversation. So now you start by going over all your symptoms again, listing all the ways that is impacted in your life, whether you have to miss school, you have to miss work, whether it's affecting your career growth, whether it's affecting your overall quality of life. List all of that and then crown all that with a statement like this: I'll feel much more supported if we could organize a referral. Would you be willing to do that for me? So now, you didn't just say you want a referral. You've reminded them all the symptoms and how it is affecting your life, your education, your career growth, your relationship, and all that, and how unsafe it is making you feel, and what you think can make you feel safe, and then inviting them to collaborate again. Is this something that they will be open to give you a referral? It becomes even more interesting if fertility is a concern for you. And so if fertility is a concern for you, then you need to inject that into the conversation before you request for the referral. And so it could also go something like, I am also starting to think about my future fertility, and I have read that endometriosis can sometimes make it difficult to conceive. I would like to talk to a specialist early so that I can understand my options. Would you be open to referring me to a gynecologist or a fertility service that knows about endometriosis? And so now you are not just speculating about it. You think that if it is endometriosis and it is not detected early enough, it may have an impact on your future fertility, which is something that you're worried about. And it could even affect your emotional stability even more. So you want to be able to identify it if it exists and know how to plan your fertility journey or rule it out if it does not exist, so that you have free of mind to think about how to manage the pain, rather than managing the pain and thinking about possible fertility or having to rush conception because you think if you wait further, then you may be too late. And so you are gently asking for collaboration and not necessarily demanding it. So then, probably the final thing is, what if your GP is still hesitant? It's still valid to want to know why they are not open to offering you a referral at this stage, and you can ask for this very calmly. Can you help me understand what makes you unsure about referring me at this stage? What this can do is to reveal to you if there are any legitimate concern coming from the GP side for which reason they don't want to give you a referral that you're looking for. And then once that explanation comes, if it does, don't just dismiss it. Remember, when you were dismissed, you were not happy. You don't want to dismiss someone if they also have concerns that they think are legitimate to them, even if it is not legitimate to you. So you acknowledge whatever reasons that the GP brings up to explain why they are unsure about giving you a referral, and then reiterate again that even though you understand it and you thank them for explaining what it is, you are still worried because of the symptoms. You bring all the symptoms again, and it will be easy to do because you've already documented all these things, and throughout the appointment all these symptoms have been mentioned over and over again. And then you mention all your symptoms and how they are affecting your life, and then ask, would they be willing to offer you a referral if you tried maybe a month or two, whatever recommendation or treatment that they are giving to you, and it is not working, so that you could revisit the discussion, ask for it. So I understand what you are saying, but my pain is severe, significantly tied to my menstrual cycle, and it is interfering in my daily life, relationship, education, and school. And so if I try this treatment options you've given to me for a month, for 2 months, and I don't see any improvement, will you be willing for me to book another appointment so that we could revisit the idea of referral? If you are still at a roadblock at that point, that's fine. You still don't have to be rude. You still don't have to do anything. You don't have to raise your voice. As devastating and as bitter as such an outcome would be, just thank the GP and get out of the consultation room. It is okay to seek a second, a third, even a fourth opinion. Remember, the aims for which reason the appointment were booked are still the things or the outcomes we are looking for. If we don't get it from the first GP, the second GP, the third GP, we don't rest until we finally get the outcome that we are looking for. So it's okay to thank them, get out and walk from the consultation room and try and see another clinician. I know it's not supposed to be this hard. Ideally, once you've documented your symptoms over a period of time and you have in-depth knowledge about what endometriosis management guidelines have listed as red flags, it should be simple and straightforward. But it's not. We know the systems needs to change, but we can't sit down and wait for the systems to change before we get relief. So we are going to chew gum and work at the same time. Try to advocate for ourselves and get the help that we need now while we are waiting for the system to change, so that endometriosis care, diagnosis, and management can be as seamless as various other diseases. We'll do this together. What do you think? Does this fit with your own experience? If there's any other way you think will make communicating with a dismissive GP about your endometriosis symptoms more seamless, share it in the comment section. If this was helpful, let us also know in the comment section. Share the page and its content with anyone you think can benefit from its content. Endometriosis Voices, listening to lived experiences, learning from science.